Good afternoon and good morning, everybody. Thank you very much for joining us today for our Heart and Stroke webinar. We had a very exciting week last week when we did something very novel and released a new report called Disconnected, How Unseen Links Are Putting us at Risk. This is a very different report for us and goes into a lot of new concepts, and today's our opportunity to explore some of those more. So I'd like to introduce you to our panel today. There's myself and Dr. Cindy Yip, who's the Director of Knowledge Management, the Heart Program at Heart and Stroke. And our special guests are Jennifer Monaghan, who's going to speak on these topics from the perspective of people with lived experience, Dr. Sharon Mulvagh, who's a cardiologist in Halifax, and Dr. Jeffrey Habert, who's a family physician in Toronto. So all of our speakers are very versed in these topics. They've been integral in helping us develop this report and speaking to media this week, and so we welcome and thank them all. Dr. Habert and Dr. Mulvagh's disclosures are here on the screen for you to look at. Great. So we will start this presentation with just a quick overview of what's actually in the report, and then we'll dive into some specific issues by our three panel members. So for this report, our goal is to align with our new strategic directions at Heart and Stroke, which is to immediately transfer knowledge to action. We've been working with 6 advisory councils throughout the last year. Cindy and I have been working with these councils as well as a broad team here to understand across all of the major conditions affecting people, with their heart, their stroke, or vascular cognitive impairment. What are those major issues? What are the gaps in research knowledge, in systems change, and then patient care that we need to address? So this report is a very strong statement from us, talking about we can no longer think of these conditions as isolated and individual, but they are very much interconnected, and we have to start thinking of them and changing our practice in the way we approach them. So first of all, you'll see in the report a reference to heart, brain, and mind. We're not changing the Heart and Stroke's name to Heart, Stroke, and Mind, but it's important for this report that we wanted to highlight the importance of vascular cognitive impairment. It is a vascular issue, just like heart and stroke are, heart conditions and stroke, and it's very much an area we're interested in around the vascular cognitive impairment. So therefore, we kind of use that term as a way to kind of sensitize and introduce the fact that this is very much a space Heart and Stroke will be working in with all of our stakeholders across the country. An important part about this report is none of our concepts focus just on one part, like the acute part of an event, but it really looks at a broader systems perspective, so across the continuum of care and even beyond the healthcare system. One of the things we discovered to start out was what exactly are the relationships between the heart condition, stroke, and vascular cognitive impairment. So we did a very extensive review of the current literature and evidence, and what you see on this, what we call a heat map, is all of those colored dots indicate areas where there are relationships between our conditions. For example, if you look across the row for all of the conditions that might be associated once you've had a stroke, you see a red dot under vascular cognitive impairment. What this means is if you've had a stroke, you're at much increased risk of vascular cognitive impairment. Similarly, if you go down 2 levels to congenital heart disease across the row, you'll see that anybody who's had a congenital heart defect is at increased risk of most of our other conditions. So cognitive impairment, as you'll have seen from the heat map, is lit up across the board. So every condition we looked at does have an increased risk of cognitive impairment, mainly due to compromise in blood flow to the brain, reduced oxygen and nutrients, as well as changes to the vessels themselves. Here are some examples. For example, somebody with atrial fib has a 1.4 increased risk of vascular cognitive impairment. Somebody with heart failure has 2.6 times increased risk of having vascular cognitive impairment. These are really significant, and we need to start sensitizing people, hence the idea of the heart, brain, and mind. Here are some of the papers and examples we used of even looking at people who've had vascular cognitive impairment with stroke, with atrial fibrillation, and with heart failure. The one thing we also discovered, which is really important, is that it's not just about having one condition. 2.6 million hospitalizations were studied in Canada over a 10-year period. And what we discovered, first of all, is when you look at vascular cognitive impairment as part of it, we have somebody dying in Canada once every 5 minutes from these conditions. So over the course of this webinar, there's going to be 12 people who will die from our conditions. As system leaders, we need to be aware and educate. I will now turn it over to Jennifer Monaghan, who's one of our volunteers, and she is going to talk us through a little bit of her own personal experience with these conditions. Jennifer, over to you.
Thanks. So as a younger person with no family history or risk factors of having a stroke, I had no idea what a stroke was, let alone the signs of one. I mistakenly thought it was something only seniors had to worry about, until I had one. At 43 years old, I suffered a devastating left middle cerebral artery thrombus, and I could not speak or move my right side. At first, I thought I had merely lost my voice. I could not begin to comprehend what was happening. Luckily for me, my husband was with me, and he realized what was going on and called 911. I got to the hospital quickly, and a neurologist met me there and administered TPA for my blood clot. My family and friends leapt into action, supporting me, my husband, and my children. I spent over a month in the hospital and was discharged without any definitive reason why my stroke happened, without any plan for recovery, with no one to guide me. I needed a better idea of what had happened, what resources were available to me, what might happen next, and where I needed to go. Instead, I felt like I was alone on my road to recovery. Unfortunately, that road took a detour when my heart worsened. Although I was aware of a problem with my heart after my stroke, I didn't give it much thought because it didn't cause me any pain or stop me from doing anything, and because my ejection fraction was just slightly low and had stayed stable for over 6 years. Until last fall, when my yearly echo showed a substantial drop in ejection fraction. Now I'm being followed closely by a cardio team, but I feel like they are not connected to my stroke experience. And my stroke team never expressed concern over the likelihood of me developing heart problems. After surviving a stroke, I assumed I was done with serious heart problems, health problems. I didn't know the heart and the brain were so connected. When we asked what had caused these problems, I was told my stroke might have happened because my low ejection fraction. And a cardiologist could initially only tell me that my heart might have had a virus. Not knowing conclusive answers was hard. Now I am anxiously awaiting another echo and an MRI of my heart 4 months after my last echo, to hopefully tell me why my ejection fraction has dropped despite the medications I've been taking and my healthy lifestyle. Getting access to rehabilitation therapy was a challenge. My speech was terrible and I needed physical therapy to regain my right side. Fatigue and my confusion at the time played a part then. Finding therapists on my own was difficult. Luckily, I had the drive to recover and the money to pay for supplemental private therapy. Many people with strokes do not, or they live too far from therapists and it isn't even an option. I think we need to better educate the patients, like myself, and the public about the connections between heart, brain, and mind. When I was asked to be a member of the Heart and Stroke's new Council on Vascular Cognitive Impairment a few years ago, I had never heard of that term. I read about my, quote, definite and significant deficits for cognition, including memory and executive functioning, end quote, 3 years after my stroke, when I requested a paper copy of my hospital file. Since my stroke, I have had to see many related specialists, 8 so far. And I've even had to get a new family doctor when mine retired. None of them had access to my health records. And I often felt like I didn't understand what the others had said to answer the questions of the specialist I was dealing with at the time. I would love to have a patient card with a swipe code for me to take to all my appointments that gives them all my health records electronically. The stats in this report are very alarming to me. As a woman who had a stroke and who is now experiencing heart failure, those stats show that I am significantly more likely to experience premature cognitive decline. I don't want to be on the fast track to dementia. As someone with all three conditions, I am concerned about the healthcare system's ability to treat me when I need it, for whatever I may need, and as long as I may need it. I'm not even 50 years old. I am facing a very long road ahead to be living with and managing these heart, brain, and mind issues. I would love to have some kind of plan to avoid premature cognitive decline, perhaps baseline testing now and annual follow-ups, and if it is found, treatment for it. This is a picture of my family after my stroke, when my kids were just 8 and 10. To conclude, I had the drive, support, time, and resources to spend on adjusting to the new normal. That is not the case for too many others. Other people with lived experiences, even with only one of these conditions, experience challenges navigating the health system. And these are even harder for people living in rural and remote parts of Canada. The Heart and Strokes Facebook page for survivors is an awesome opportunity for patients to learn from and draw support from others. It also provides proof that those patients are not always aware of the connections between heart, brain, and mind. For instance, this patient says, I was told I would have no cognitive issues. Clearly, her brain was impacted with 2 strokes, but she was led to believe her mind would be fine, and it wasn't. I will now pass this over to Sharon to address connections to heart conditions and highlight some specific challenges for women. Thanks.
Thank you. Thank you so much, Jennifer, for sharing your story. It's extremely compelling, inspiring, and very deeply concerning, pointing out the disconnectedness in our current healthcare system in caring for our cardiovascular patients. And I really appreciate you sharing that.
Thank you.
If we could advance the slide. Thank you. So, as you can see, cardiovascular disease is extremely impactful to the Canadian population. And indeed, in the current report that the Heart and Stroke has released, they evaluated hospitalizations over the decade between 2007 and 2017 for the conditions of heart, stroke, and vascular cognitive impairment. And the breakdown of these hospitalizations is here, as you can see. 2.6 million hospitalizations in a decade. And the majority of these were actually heart conditions, followed by stroke, and then vascular cognitive impairment. You can note here that there is some sex and age differentiation. Women tend to become more afflicted as they age. There are more men in the younger years. More men have the diagnosis of coronary artery disease, but women are equally impacted by heart failure, by stroke, and by heart rhythm disorders, as well as structural heart disease. It is concerning that structural heart disease has increased by 50%, the diagnoses over the last decade. Similarly, 35% increase in vascular cognitive impairment, 25% increase in heart failure, and strokes increased by 20%, atrial fibrillation by 5%. Those are the statistics for the hospitalizations. And the issue is that our patients are becoming more complex. We know this. We know that the patients that we see are more often going to have another associated heart, stroke, or vascular cognitive impairment condition. And this is a nice graph to represent that in those patients that have been admitted with heart conditions, they often have stroke, or they often have associated vascular cognitive impairment. And the flip side is that those with stroke similarly would have heart conditions or vascular cognitive impairment. So the acuity of our patients is rising. This is both in men and in women. The really impactful thing that came out in this report is that of those 2.6 million hospitalizations for heart, stroke, and vascular cognitive impairment conditions, 40% of the patients who were discharged after those conditions were readmitted with a second condition that was either the same diagnosis or a related diagnosis. This is really worrisome, and we know this, we see this. So what this tells us is definitely that our vascular system is the highway connecting our brains, our hearts, and of course our brains control our minds. And our patients that have one system affected are at a significantly higher risk for another system to be affected. Indeed, the percent of patients who came back for a heart condition exceeded those who came back for stroke or vascular cognitive impairment. But as you can see, the proportions are huge when we look to see our efforts at secondary prevention are not really working, it seems. And the worrisome thing is that there are sex-specific differences. These risks are even higher for women than they are for men. And it is amazing to note that in 2016 alone, 12% more women than men died of heart conditions, stroke, or vascular cognitive impairment when put together. Heart disease, stroke, and vascular cognitive impairment are the leading cause of death for women. We saw that we are very much underserving our women with our reports last year from the Heart and Stroke that both addressed heart and stroke conditions. 23% more women than men die of heart failure. Women are at a higher risk of atrial fibrillation, and when they have atrial fibrillation, they're at a higher risk of stroke, and they do less well when they get that stroke if it was because of a cardioembolic cause. Moreover, women that do suffer a stroke, 45% more women die of stroke than men, and because women tend to be older and live longer, they live longer with disability. This is not good for the quality of life for our Canadian population. I tried to advance there. I'm sorry. I need some help advancing, please. Patrice, can you advance, please? Thank you. When we look specifically at why these factors might be, we note that although women do tend to present with chest pain as often as men do, what happens is that women are far more likely to have associated signs or symptoms. And these can be misinterpreted and not understood to represent cardiovascular disease. Women more often have pain in the upper back, shoulders, and in between the scapula. They more often have shortness of breath or extreme fatigue, as well as nausea or even epigastric pain. You're going to have to advance for me. I'm sorry, I can't operate from here. So that it can be very confusing for our healthcare providers to be able to understand and even think about chest pain as non-chest pain symptoms as being representative of cardiovascular disease. And therefore, we're missing a lot of diagnoses in our women. Next, please. I'm not able to advance here. Thank you. And our younger women have even more problems when it comes to getting the right diagnosis. We hear the expression frequently, stopped at the gate, because we are not thinking about a young, healthy-looking woman who could possibly be coming in with SCAD, spontaneous coronary artery dissection. We are recognizing now that this is a very common diagnosis among women, particularly less than 50, who have no cardiovascular risk factors. And previously, they have been flying under the radar and not doing well because of this. In-hospital mortality for women from cardiovascular diagnosis exceeds that for age-matched men. Next, please. Thank you. And this is not only true in the United States, which represents these statistics, but we have found the same issues in Canada. Young women, less than 55, have greater comorbidities, they have a greater length of stay, and a greater in-hospital mortality once they finally get in the hospital after the diagnosis is made, which is often delayed. Next, please. Another reason why we might be missing the boat with women and being able to understand their heart and brain and mind diseases are because women have emerging risk factors, unique, sex-specific, unique risk factors, specifically gestational diabetes and hypertensive disorders in pregnancy have recently been recognized as increasing cardiovascular risk. Similarly, our traditional risk factors, certain of them are more impactful in women than in men. And in women, it would certainly be an issue with respect to considering smoking. A smoking woman is at higher risk of having heart disease than a smoking man. Similarly for diabetes. A diabetic woman is at a higher risk of having a heart attack and a stroke compared to a diabetic man. Next, please. This underscores here the fact that this not only applies for heart conditions, but also for stroke conditions. Hormonal status changes, we see this. A pregnant woman who has a heart attack, it's almost always going to be SCAD. A woman who has atrial fibrillation, as I mentioned, is at higher risk of having a cardioembolic stroke than a man. Next, please. The other unique diagnoses that we see in women, cardiovascular diagnoses that we don't see as much in men, would be broken heart syndrome or stress-induced Takotsubo cardiomyopathy and small vessel coronary disease. Many times women are misconstrued in understanding of their heart attacks because their coronary arteries are clear and there are no significant blockages, but yet they've had a heart attack. Minoca is something that has come to the forefront, and women exceed men in this diagnosis. Women are also very much more likely to have vascular reactivity disorders such as vasospasm and associated primary pulmonary hypertension. Please advance. We must think somewhat differently when we come to approach our female patients in their evaluation for their suspected cardiovascular symptoms. And a myriad of testing is available to us, and oftentimes this requires specialized care to pursue. Fortunately, there are centers of excellence that are under development at the current time with respect to cardiovascular care for women. And we need to work together to combine with our neurology colleagues as well as our vascular colleagues and our cardiologists. But key is to be able to communicate this information to our primary care colleagues so that they understand those important connections between heart and brain and mind, and how women are even at more risk than are men. So the challenges are a myriad. We have challenges with respect to prevention, recognizing unique risks, recognizing symptoms that have been not perhaps typical in women, but that's because we learned what the typical symptoms were in men. We have an important responsibility as healthcare providers to understand that the pathophysiology can be different of cardiovascular disease in women when it comes to men. We need to encourage our patients to know their numbers, to recognize the risks, and to act upon those risks. And we need to encourage our policymakers to enable an environment where it is more easily available to our population to activate those changes in positive lifestyle habits. So I think that this summarizes quite a bit this is a very important report, which has brought together the concepts of the holistic model of care and how we need to get out of our silos and work together to support our patients and be able to recognize their needs in their cardiovascular concerns, and to be able to give that common language to be able to communicate well with our patients and to extend the communication beyond the patients to the community and their care providers. And on that note, I'm going to turn it over to Jeff, who will follow through on speaking more directly to the role of primary care physicians in the essential care for our cardiovascular patients. Thank you. Jeff?
Thank you very much. Okay, let's see if I can advance. I think you guys are going to have to advance for me, so go ahead. Okay, thank you. Go back one thing. So thank you very much, first of all, to Heart and Stroke for highlighting this connection between heart, brain, and mind. I think it's very relevant and certainly relevant to our entire population. Thank you, Jennifer. I think your story was very, very eye-opening, and I think it really gave everyone an indication of what people really go through, especially young women. And Sharon, thank you for that. I think it was very eye-opening, and it's something that we do see in family practice, and we're slightly aware of it, but I think you really brought it to the forefront, so thank you. I want to talk about the role of family physicians and primary care practitioners. We really are the first point of contact in the healthcare system. Many times the patients don't go to Emerge, they'll go to our office. The typical family physician has a roster of 1,500 to 1,800 patients, and they're helping these patients navigate the system. So often the referral is indicated and it's very difficult to navigate. Often the referral may not be indicated, but the patient or the patient's family's saying, I really need to see a specialist. I think I have this or I have this. So we're trying to always navigate the system, and it's not always so easy. We have always spent a large proportion of our time taking care of the heart, brain, and mind, whether it's directly or indirectly, individually, dealing with coronary disease or heart failure or stroke or dementia or depression. We've been taking care of these things, but we're often called upon by family to do something. Sorry, I just got to turn this off. And often that means we have to navigate a system, and as you've heard, is not so easy to navigate. But the one good thing we have is family doctors, we have a toolbox that is really growing rapidly, and that's what I'm going to talk about. So first of all, we've always been focused on primary prevention, control blood pressure, smoking cessation, control lipids, diabetic control, healthy diet, and regular exercise. We've always done that. But we have a toolbox that is growing for medications, and especially secondary prevention now. We use statins, ACE inhibitors, we try and control hypertension, we use antithrombotics, and we always talk about healthy diet and exercise for secondary prevention also. Next slide. The burden of cardiovascular disease is enormous. It's certainly one of the biggest things that we deal with in family practice. I mean, if you look at the big four in family practice, it's hypertension, coronary diabetes, and mental health. But 90% of people in Canada have at least one risk factor for heart conditions, stroke or vascular cognitive impairment. That's a huge number if we think of the enormity of the population and the amount of patients that are going to have issues. We also know that cardiovascular disease is responsible for about 1/3 of all deaths globally in patients over the age of 35. Next slide. So these are approved pharmacological therapies for CV prevention. This is what I would call our basic family physician's toolbox. We've been using beta blockers and other blood pressure lowering medications. We have glucose lowering medications. We have LDL cholesterol lowering medications. We've been using statins for years. PCSK9s are a little bit newer, so that would be a new tool in our box. And we've always known about ACEs and ARBs for years, and we've been using that. And we've had antithrombotic therapies like aspirin or clopidogrel, and we've had those. Go forward. So we use them because there's evidence for using them. So we've known for years, and I'm going to talk about MACE. MACE is major adverse cardiovascular events, that's stroke, MI, and cardiovascular death. So we know that lowering your lipids by 1 millimole lowers MACE by 21%, lowering blood pressure, similarly, everything's about 21%. So lowering blood pressure using an ACE in a CV patient lowers MACE by about 20%. But if you look down, we also protect our patients from stroke, MI, and overall death. So this is what's in our existing toolbox. These are drugs that we're using now. Next. And we've done a really good job. I mean, if you look at this is 2016 data, and it's getting better. We're really good at using the tools in our toolbox that we have available, especially for secondary prevention. Our use of statins, beta blockers, ACEs, and aspirin is 80% or more. So we've done a really good job. Next. But now we have new tools. So I want to talk a little bit about the newer tools. This is an article that was published just over a year ago in New England Journal of Medicine, Compass. And it's talking about that in patients with chronic coronary disease or peripheral arterial disease who don't have AFib, when we add aspirin to very low dose rivaroxaban, this was shown to reduce major cardiovascular events. And the reason I'm bringing up Compass is because it applies to such a large percent of the population. And once again, it's another tool in our toolbox. Next. So the Compass trial looks at a very large population. If we look at the REACH registry, so in REACH, they looked at patients with known heart disease or those at very high risk, had 3 risk factors. And in the REACH registry of almost 32,000 patients, over 50% of them would have been eligible. So in a typical family practice with 1,800 patients, about 1,000 of those patients that wouldn't be right. But in a typical family practice, in those patients with coronary disease or stroke or PAD, over 50% of them would be eligible for Compass. So that's a large percentage of patients that are now going to present to our offices for which we would consider using a Compass regimen. The main reasons they were excluded from Compass based on the REACH registry: high bleeding risk, they were taking oral anticoagulant maybe for atrial fibrillation or something else, or they were already on dual antiplatelet therapy. Next slide. What Compass showed, and this is why I'm bringing it up, Compass reduced MACE 24%, but what's most relevant here is this was on top of usual therapy. So these are patients that are already getting statin, aspirin, ACE, maybe beta blockers. And in addition to that, by using the rivaroxaban in addition to aspirin, we reduced MACE by 24%. And as you can see down, reduced stroke an impressive 42%. So that's why I think it's an important tool, and we're going to become more familiar with it. It's relatively new in primary care. We're just getting comfortable now, and I think it's relevant for us to know. Male at the bottom is major adverse limb events. Next. So let's look at the vascular protection box. As primary care practitioners, we always work on healthy diet, physical activity, exercise, weight control, psychosocial support. And if we have teams, it's even better. We have physicians, nurse practitioners, diabetic educators, nutritionists, social workers. And if we have that kind of practice in a family health team, it makes it even easier. In addition to that, we have the traditional therapies. We have the antithrombotic therapies. We have statins and ezetrol. We have blood pressure medications. And we've always had glucose control. We've been using insulin and metformin for years. But now the new generation, our toolbox is starting to get a lot bigger. We now have the Compass regimen with rivaroxaban plus ASA. We have the new lipid medications, the PCSK9s, which reduce cholesterol levels over 60%. We have new cardiac medications that can be used for patients with reduced ejection fractions and have decreased hospitalization for heart failure and mortality at about 20%. And we have a whole new group in the last 3 or 4 years of anti-diabetic medications. Next. I want to address diabetes quickly because it's so relevant. In 2015, it was 9% of Canadians. By 2025, it's estimated to be 12% of Canadians. This is type 2 diabetes. And as I mentioned before, it's certainly one of the most, not important, but certainly most common things that we treat chronically in family practice. And This is from Diabetes Canada guidelines, where they have a vascular protection checklist to reduce sugar, reduce blood pressure, reduce cholesterol, use the drugs that have shown CV benefit, and once again, exercise, healthy eating, and smoking cessation. So these are the A, B, C, D, E, S's. Next. I'm going to talk about 3 relevant trials that have come up, which Diabetes Canada adopted very quickly. The first of which, next slide. The first of which is EMPA-REG, which showed a 14% reduction in MACE and also showed a significant reduction, 38% in CV death. So EMPA-REG was with an SGLT2 called empagliflozin. As you can see at the bottom also, it also decreased hospitalization for heart failure and all-cause mortality. Next. The next slide with liraglutide, the LEADER trial, so this is an injectable GLP-1, decreased MACE by 13%, next slide, but also reduced CV death by 22% and also reduced all-cause mortality. And the next slide. Then we have the CANVAS trial with canagliflozin, another SGLT2, also reduced MACE by 14%, very similar to the other 2 trials, and also reduced hospitalization for heart failure by 33%. The reason I'm bringing these 3, because there have been CV outcome trials since then that have been positive, but have not yet been adopted by Diabetes Canada. Diabetes Canada, next slide, has adopted these 3 because the last update of the guidelines, these 3 trials were available. And now they say, Diabetes Canada now says the first thing we need to look at after a patient is on metformin is whether they have clinical cardiovascular disease. So that's exactly what we're talking today. Has the patient had coronary disease? Have they had peripheral arterial disease? Have they had a stroke? And if yes, then we should use one of these 3 drugs with proven CV benefit. As mentioned, there have been 3 trials since then that have shown CV benefit, and I suspect this year that Diabetes Canada will adopt them. So our toolbox is getting so much bigger, and there's so many more ways that we can help our patients. Next. So prevention is critical. I think primary care practitioners, nurse practitioners, family doctors are play a critical role in this because we're often the first point of contact. But we need to raise awareness among the public, healthcare providers, and system planners and funders. Heart and stroke has been very effective with symptoms of stroke and things we can do. Governments really do need to play a role to help us enable these healthy environments and have more global population health prevention policies and strategies. We need to have money so that our researchers can identify better ways to make prevention successful. As I mentioned, healthcare teams are so useful, and unfortunately, not all primary care practitioners in Canada have access to a team of educators and nurse practitioners and social workers, but the ones that do, that's beneficial, and hopefully that'll become more the norm. Employers also can play a critical role. Heart and Stroke is conducting employer-funded pilot study to provide health coaching to consumers and employees, for example. But I think foremost is individuals, patients. Our patients need to act on their own. Thank you very much, and I'm now going to hand it over to Cindy.
Great. Thank you very much for our amazing speaker, Jennifer, Jeff, and also Sharon. And really, the report, really what we're trying to do is really call everyone, not just the physician and not just the nurses, but everyone, meaning healthcare system leaders, the patient, the family, the caregivers, and organizers like Heart and Stroke to all come together because we need to move forward and move towards to a more patient-centered, family-oriented model that can efficiently meet the needs of people who we in the report has highlighted. Apparently, we are all suffering more or at higher risk of more conditions than we think. And, how we can all come together to work through the recovery phase and to find the right support and navigate through the system. It's the whole 9 yards of this whole story of where we are trying to get everyone together to call for action immediately. And I think one thing that I do really want to close this webinar with is a very powerful quote that came out from our interview through our research for this report. It's by Dr. David Hogan. And really, echoing to some of the things that has been talked about in this webinar is that his, as you say, his practice is defined not, shouldn't really be defined by just age, but what he is seeing today is that his practice is currently defined by the age of the patient and not whether they have a particular disease. So really looking at how we can all come together to provide support and the care that is relevant to individual, and how we can work with the patient together to make the right decisions for the best outcome for many of you that are at risk or will be at risk or are currently living with multiple conditions is what we are trying to share this message with everyone to help us amplify this message. So with that, we would like to open up for questions. Please submit your questions on the webinar. And while we give the audience a few minutes to do that, maybe I will open up with the first question to our first speaker, Jennifer. So maybe if you can spend a few minutes to kind of share your experience of what helped you navigate through the system during your journey.
Well, I spent a lot of time using the yellow pages when I first was released from the hospital, trying to find a physiotherapist. That was a bit of a dead end. So I went to one physio and asked them who in town was experienced dealing with stroke survivors, and they gave me another name. So I just had to get out there and try.
Mm-hmm. So I hear the communication and continue working with your healthcare team is absolutely important in your navigation then.
Yes.
Our next question is actually for both Jeff and Sharon. Maybe Sharon, you can start. As we're starting to think about these diseases interconnected and the fact that they're being treated at the moment by different people, what is your worry around polypharmacy and compliance issues and interactions, and how do you manage that? So Sharon, do you want to comment first, and then Jeff?
Yes, I mean, it really is a big concern. I think that fortunately, most of the drugs that we use to help with cardiovascular disease are beneficial and complementary in many ways. But it does behoove the prescribing practitioner that they are aware of potential interactions. I mean, some interactions are very complementary, and so, we would be able to improve conditions with the polypharmacy. But I think the key thing is to have, and this is to Jeff, is to have that primary care provider is really the one that comes down to reviewing the prescriptions and making sure that there isn't any redundancy or any problem with negative interactions. Jeff?
Yeah, I agree totally. I think the biggest problem we have is when patients have been in hospital, sometimes we don't get the report on time because their medications have all changed and we don't know that. So if I know they've been in hospital, I'm going to see them. I'll have my secretary call them and say, please bring all your meds in a bag. And I try to do that as often as I can. But it's often difficult and it's often caught by the pharmacy. The pharmacy will send me a fax and say, oh, your patient was started on this drug. Do you want to renew it? And I look in the record and I have no clue. Or they would have seen a cardiologist or a neurologist, and in the middle of their note, they would have added a medication, and I didn't catch that line, so I don't have it there. Or they're still on an ACE, and someone in hospital added an ARB because they didn't realize they're on an ACE. So electronic records have made this a lot easier because we're getting discharge summaries immediately. So usually it's not a problem, but it often happens. And this is where I find the pharmacist invaluable, because the patient will leave hospital with their prescription, go to their pharmacy and hand it in. And when I renew their drugs 2 months later, the pharmacist will nicely say, oh, Jeff, you forgot this drug. They were started on this 2 months ago. And I'll say, oh, thank you very much. But I think it highlights that the system is not totally yet fixed because we're not getting this in real time. And I think once we have a national pharma system, which really is coming, and we will see that in the next year or two, it's going to make this a ton easier because you'll be able to dial in and know in real time what drugs our patients are taking.
Thank you. Next question directed at Sharon. Is there a specific role you see for first responders, given the male-female differences in presentation for heart attack and other heart conditions? How do we educate them, and what's their role?
I think this is key. There is clearly a role, and I might suspect I might know who this question is coming from, Christina. It is actually an unrecognized opportunity that we have to be able to help, particularly our female patients who present often with major riddles or conundrums to their care providers. So yes, our EMTs, our first responders, they are key in the part of the education process and also in the recognition and the communication to the emergency room staff when they bring in patients that have very suspicious symptomatology or, confusing symptomatology. I think it's key, and I really support that. And I'm really enthused to see that there are some excellent first responders in our communities that are dedicated in this direction.
Okay. So we have quite a couple of different questions from the audience about exercise. We talk about a lot of prevention, a lot of managing your risk factor in your report and also in your presentation. So a couple of the audience have asked, why isn't exercise prescribed in the same way in content as drugs? What are your thoughts on that?
I mean, I can take it first because I'm most guilty because I had a drug-based part of my presentation. And I cannot, whoever asked that question, I cannot agree more. Exercise is so relevant. It is medicine for the heart, it is medicine for the brain, and it is medicine for the mind. We have no one drug that can do what exercise can do. And I really wish, someone used the quote, I've heard some quoting someone else, that we wish we could put exercise in a pill because it'd be so much easier. But there is no stronger drug than exercise. And I think as healthcare professionals, we all know that, but you're right. It's underemphasized. Look what I did. So relevant. So thank you for that question.
And I can only echo what Jeff said with respect to that. Clearly, it's Life's Simple 7, and the first 3 things are lifestyle. Don't smoke, or if you do, then certainly stop. Be active, i.e. just move more, and eat healthy. And then it comes down to knowing your numbers and getting appropriate treatment for those numbers if you have conditions of high blood pressure, high glucose, i.e. diabetes, or high cholesterol, and having a healthy weight and trying to achieve a healthy weight through your number of your body mass index and waist circumference. 100%.
Thank you. The questions have been pouring in, so we may not get to all of them, but we'll do our best to get to a few of them. Here's a really important one, and I'd like all 3 of you to comment on it, maybe starting with Jennifer. So at what point, considering the interconnection between these conditions, at what point do we consider cognitive issues and try to tease out the difference between natural aging and there being issues directly related to the event, the cardiovascular event? And should there be routine screening for cognitive impairment for anybody having any of the conditions we've addressed? So Jennifer, why don't we start with you, who is a person who has experienced these? Do you feel that you should have been screened before you had to advocate for yourself?
Yes. I was tested when I was still in the hospital, but that was almost 7 years ago. And I often ask myself if I've, forgotten something or can't figure something out, or a problem, it seems harder than it used to. I ask, well, is this just my getting older, or is it to do with my health issues? And many of the people who I've seen as a facilitator with the Living with Stroke program, they're in the same boat. We have no idea, and I think we need better screening. And I would also like a annual follow-up on that screening.
So Sharon, when is the right time to start screening for these? And should it be routine in every follow-up clinic, or what is your thoughts on this?
Yeah, I think we just don't have any data on that right now. Patrice, I really think that with respect to specifically assessing cognitive function, usually it takes some degree of symptomatology to surface, and then the investigations would ensue. But I do think that what we need to do is to be more astute to recognizing the increased risk, and that if there is anything that is suggestive of a cognitive impairment, that be evaluated at that time, that would trigger an evaluation. In the interim, it's really key to recognize that the secondary prevention that we do after one condition has been diagnosed and treated, be it heart or stroke, that it is protective of all three conditions. And that it's extremely important that we manage our risk factors. And unfortunately, I think in the survey, it showed that maybe only not even 40% of Canadians, that if they recognize that they could get more bang for the buck by protecting more than one condition, that they might, actually practice preventative measures. That's a bit concerning. So we've got to get the message out that a healthy vascular system is a healthy brain, mind, and heart.
And Jeff, so you're the one who sees all these patients on a regular basis after their event. What is the onus on family practice and family practice teams? Should they be screening, or how do you manage it? Do you wait for symptoms?
I agree with Sharon. I think realistically, I'm not screening. We're waiting for symptoms, but I think we need to recognize educationally exactly what this report said of the connection of the heart, brain, and mind. So we do wait for symptoms because the patients had their stroke or their heart attack. They typically also have something else like diabetes, or maybe they have some heart failure, and we're seeing them in 10 to 12-minute portions, and we're dealing with the things that are in front of us. So the diabetes or the coronary disease, we're not looking for the things that aren't presenting until they present. But I think what's most important is we have to look for those subtle early changes if we know that they're coming, because we know of the connection to look for them. But I suspect that as primary care practitioners, we are guilty. We are not screening for this disease that's not symptomatic and that isn't presenting in front of us, because I think practically speaking, it just can't be done.
So maybe one of the solutions that we've been looking at within our guidelines is at least for all practitioners to have the conversation, to at least inform patients and families that it's a possibility so that they're a little more attuned to watching for subtle changes rather than just dismissing them as, they're slow to recover and this is just a normal part of recovery. So one of the solutions in our guidelines is educate patients on the possibilities, and that's what we're also hoping to report, because then patients and families can take it upon themselves to also be their own advocates. So we'll turn it over to Cindy. Has a question for you now.
Yeah, so we have a question in the audience. I think it really speaks to the implication of what we talk about in the report is really more than just saying there is data that there are connections and all these different conditions interconnected. It has implication of what we do. So the question here from the audience is that, for a patient perspective, they may be taking, we're asking this patient to take more than 5, 6, or even more medications because of the interconnectedness of all these different conditions. So I guess the question is, Jennifer, as a individual living with surviving a stroke, how do you manage that? And then I think for Sharon and Jeff, from a provider perspective, how do you have the conversation, or did you have the conversation with your patient about how to manage taking multiple medications? So maybe we can start with Jennifer first.
Sure. I, got one of those pill boxes, and I leave it on my kitchen counter that I have to walk by a million times a day. And I'm a bit of an A personality type, so I'm taking them exactly as ordered, always.
You have developed a system that works for you in your day-to-day life to manage.
Yes.
How about Sharon and Jeff? What kind of conversation are you having with the patient to prepare them for this in the real world?
Yeah,
we know that. Go ahead, Sharon. We know adherence is a huge problem generally with our patients, but we're becoming more aware of the problem. We're using more combination drugs. We're using more once-a-day drugs. So we're trying to make it easier, but even though we've made it easier, we understand adherence is a problem. Our pharmacists, once again, can really help us in this regard. And I often will have a pharmacist call me and say, your patient's refilling their anticoagulant after 110 days, but you only gave them 90. So I think we need help in this regard. And I think pharmacists play once again, a critical role in helping us with that. But it's the onus is on us to ask our patients when they come back, hey, Bob, are you really taking all your medications? And how many times a week? I asked that question and I'm shocked. How many times a week do you miss your metformin? And they'll say, oh, 5. And I'm shocked, but I started asking that question, especially with metformin, because it's a twice-a-day drug, on how many times a week they miss it. So I think we have to ask and we have to be aware. Thanks, Sharon.
And one of the issues that has come up that we're dealing with is the affordability of those medications. A lot of those are very expensive, and not everybody has either access to them or can afford to take them if they don't have a very generous health plan. So what are some of your strategies, Jeff and Sharon, for people who can't afford their medication?
Sharon?
Well, I can say that maybe it's a little bit brighter. I practiced in the States for over 3 decades, and at least it's not as bad here as it is there, quite honestly. We have a much better opportunity with much more generic opportunities, and really, hopefully with pharmacare on the horizon, it will really make a difference for our Canadian population. But I do think that it's important to take advantage. Sometimes there are the coupons that can be available, and it is important to be aware of that. I'd like to step back to the last part of the question because it's still the same thing, and that is the collaborative care aspect for our patients. That brings in, the physician can't know everything that's out there on how to be able to get the best deal and access to medications that are essential. And that's the first thing, go streamline and make sure that the things that are there are only the essential things. But this is where the collaborative practice, and as Jeff has already specifically said, the pharmacists are key. I think in a lot of collaborative care practices, we need to have more nurse practitioners that have the time to sit down and talk with patients. And then the other key thing, collaborative practice and electronic health records, so that we're all on the same page. So that this is really a systems, healthcare systems and policy, and it reflects more than just on medications, as Jennifer was saying earlier. It really, for treatment plans, it's essential for the communication and for diagnosis and to break down the barriers between the different subspecialties. Electronic health records are essential. They can be a problem too, but if done right, they can really enhance patient care. So collaborative teams and electronic healthcare records, I think can help enormously.
Great, thanks. Jeff? Final comment?
I mean, for me, the affordability issue, it is a real issue. I mean, and it's the working poor. I mean, the ones that are on Trillium because of age or because of disability or because of the inability to work get coverage. The elderly get coverage. It's the working poor. And I think there's strategies we have. If they truly are working poor, they don't have a lot of assets, they can apply to governments for help. We try and help them sometimes with samples. If it's a drug that I really want to use and it's expensive, I'll go to the family and I'll say, you know what? I really think your mom needs this. Would we consider this as a Christmas gift? And those are the kind of things I'll do because I want to try and use the best medications I can use.
Awesome. So we're just about to wrap up. There's still more questions, but we will look at those and offer answers to those who've sent them. Jennifer, you get the final word before we wrap.
Thanks. I just believe that the report is trying to educate, patients and the public and the health professionals about the connections between heart, brain, and mind. And I feel I'm an excellent example of all three. And a young woman, and I'm really happy that the Heart Stroke is out there doing this work. Thank
you. And on behalf of Cindy and I, the whole team at Heart and Stroke, we sincerely thank our 3 panelists. You're amazing. Lots of the comments that have come in on the questions have been how great each of you are and how wonderful your presentations were. So thank you all. Thank you to everyone who stayed with us and watched. There was a huge number of people on this webinar. For those who missed it, please pass on to your colleagues that it will be available in a few days on our website, and we'll send up a link. Please do an evaluation. We'll send out that link so that we can have your feedback about this session and in planning other educational sessions for everybody from Heart and Stroke over the next month. So thank you again. If you haven't read the report, please do. It's on the Heart and Stroke website. And we look forward to being with you again sometime.